Hello, everyone. My name's Daphne Amavenu. I'm the Head of Improvement Programs at the Health Foundation, and I'm pleased today to be chairing a discussion with Josephine Ocklew called Being Heard, Not Seldom Heard in Health and Social Care Research and Service Delivery. So why did we want to do this session today? The current COVID-19 pandemic has shone a really strong light on the inequalities in our society through the varied prevalence and mortality rates of groups across society. We've seen a lot of media coverage about people from particular backgrounds having increased mortality rates, such as those who are Black and Asian, people who are disabled, those on lower incomes and living in deprived areas, and people in care homes. However, these same groups are also the least likely to be involved in the design and implementation of research and service delivery. Through the conversation today with Josephine, we hope to make a clear case for why it is important to take a much more collaborative approach based upon equality, diversity, and inclusion in research and improvement. And we'll have an opportunity to share some examples of how this can be done in practice to reduce health inequalities. So thank you for joining us today, Josephine. You have a wide range of professional and personal experiences to draw from, having started your career in social care, being a harmed patient, and working in quality improvement as a Black woman. So I'm very excited today to speak to you. How are you doing?
I'm fine, thank you. And thanks for inviting me to participate in this discussion. It's an important one.
So I'll start off with the first question. In this year's Q event, we are exploring how we can collaborate for a more equitable, inclusive health system. Can you start by telling us about your experience? What brings you to the table on this topic?
Yeah, it's an important question. And I think that if you're going to be involved in work like this, I think it's actually sometimes quite important to start with yourself, actually to ask yourself, why am I interested in this area? What has brought me to this topic? And I was thinking about this when thinking about participating. And I've really been interested in issues of diversity and inclusion for a very long time throughout my kind of professional career, but also, things started to emerge when I was growing up that made me think about these issues. And so I've been doing work in this area for a long time, but I think that there are kind of three areas that I think that have had a big influence on me in thinking about this topic. When I left university and I went to work in Tower Hamlets, I was working in a community organisation in Tower Hamlets. And this was my first experience of working with quite disadvantaged groups and communities. We were looking at topics around domestic violence and the kind of police harassment and racial violence. And this was an organisation that was funded by Ken Livingstone's GLC. And it was really about giving voice to people and communities who often didn't have a voice. And one of the things that I really felt that I learned from this work was that there are many groups who, because of their position in society or because of discrimination, actually don't get access to services at all, or don't get the services that they need, or get poor quality services. And this can often be impacted by discrimination. So that was kind of a first early professional experience. And then later on, as I moved into social work in my career as a senior lecturer in social work, lots of ideas and theories began to come up about, how we work with those who use health and social care services. There were a lot of challenges around in the late 80s and kind of early 90s from a range of excluded groups, Black, Asian and minority ethnic groups, LGBT groups, those with disabilities, older people. And I think you could think about these challenges more as kind of social movements who are really challenging the wider structures of society and how we provide services to certain groups in society. There were also lots of critiques about the need to stop kind of individualizing social problems, because if we did that, then we kind of didn't understand the kind of systemic structural nature of some of these problems and inequalities. And, there was a kind of strong critique at that time about the need to stop pathologizing the poor as responsible for their own poverty. And so some of these critiques really led to kind of my ideas about and my thinking about the need to kind of challenge oppressive practice in our services, and to really kind of empower individuals and communities to have a voice and to be involved. And then really my third major experience, which had a massive impact upon me, is what brought me into healthcare. And this was because my daughter died as a result of a failure to manage her heart condition. And I found myself kind of on the other side of the fence, no longer kind of teaching about these issues, but actually just a grieving mother trying to find out what had happened to my daughter and the care that she had received. And so earlier I had been thinking about, groups who didn't receive good care because of discrimination, and then found myself in exactly the same position because I felt that discrimination was involved in my care, in my daughter's care. And then really this was compounded when I wanted to get involved in patient safety and healthcare improvement, because at this point I didn't have any experience about healthcare, but because of what happened with my daughter, I wanted to try and change the system. And this is what happens to many people. This is what brings people to the table. And I really had very, very negative experiences. I found myself labelled and stereotyped as a kind of undeserving victim, because I'd had a poor experience rather than a good experience, because my views challenged a kind of dominant status quo about a no-blame culture. When I wanted to talk about the need for social justice and accountability, I was a Black woman at the table, and I felt that my face didn't fit. And even though my career in social work by then had pretty much been destroyed, and I often didn't have a kind of full-time job, and I was really struggling with finances, it was very rare for me to be offered any support or reimbursement for my time or expenses, or any induction or training or support. And so these types of things are quite typical with some of the things that happen in involvement. And, I started eventually to start thinking of myself in a similar way to Rosa Parks, as standing at the back of the bus of the patient safety movement as a Black woman, because I felt that there was no thinking around issues of equality, diversity and inclusion.
Thank you, Josephine, for sharing. It's really powerful, the experiences that you've had that contributed to you being part of this conversation. And I think you've started to touch on it, but it'd be great to hear from your experience. Why aren't patients and the public included fully in conversations about our health service? What's getting in the way?
So I think that in just outlining some of those earlier influences on me, I think that I just began to think about the broader social context. I began to think about health inequalities. And so really, rather than just starting with that individual involvement relationship, when I think about involvement, I think about that bigger picture, about communities, communities who've been excluded, who've not been able to get services, about these social structures which make that happen, and therefore the need to have kind of involvement structures that address those issues. And so for me, when I think about healthcare, I think that it's just more than a medical matter. And I just think that there are so many times when it feels to me as if we're almost just kind of individualizing everything. We're not looking at that wider social context. We're not looking at the health inequalities. And I think that this has really been brought out with the pandemic. And of course, issues to do with Black Lives Matter, that social context. And so, of course, we've seen all these awful disparities with the groups that you mentioned earlier, Black, Asian and minority ethnic communities, people with disabilities, those on lower incomes, those living in the most deprived areas, care home residents, some men in particular, and those in the poorest health. And we've particularly seen how people from Black ethnic backgrounds are really the ethnic group at greatest risk. And, these are some of the issues that we haven't been able to talk about properly in improvement circles until the pandemic. And yet the irony of some of this is that the groups who are most affected by health inequalities are often those that are least likely to be involved, both in research and social care and its delivery. And evidence really shows that the people who are most likely to be involved are those who are older, from white ethnic groups, higher socioeconomic backgrounds. And this is something that we've known about for a very long time. And so a few years ago in 2016, I wrote a paper called From Tokenism to Empowerment to try and flag up what, some of these big issues were about, why we were not kind of involving a whole range of diverse groups, particularly groups from across the protected characteristics. And I feel that when I first started to talk about this, certainly when I was in improvement spaces, I just felt that people didn't really kind of take it seriously, didn't seem to understand what I was talking about. And so in the paper, I kind of set this out in a bit more detail, the importance of kind of making diversity and inclusion absolutely central to the type of involvement that we were trying to carry out and in our conversations with patients and the public. And I also set out in that paper issues around paternalism, that what I was really saying is that the model of involvement that we currently have has kind of almost been co-opted from the one that first emerged in the late 80s and 90s, which was driven bottom up from social movements. Whereas now, what we often have is a kind of paternalistic, top-down and professionally controlled type of involvement. We often have tokenism, where we get the kind of handpicking of one or two individuals, and those individuals have often had good experiences rather than poor experiences.
And you started to touch on some work that you're doing to address some of the barriers that you raised. And I know you've been leading great work in this area. Can you tell us more about this and what can be done to practically address some of the challenges that you've raised?
Sure. So more recently, I published this paper, Being Heard, Not Seldom Heard. And you note that I use this term, democratizing research with diverse communities during the COVID-19 pandemic. And I used that term democratizing because we could change it for democratizing involvement in service provision and care. But the important word is around democratizing, because I think at the moment we have a situation where the involvement agenda, in effect, reflects all the hierarchies that we see in society with respect to kind of race and gender and disability. And so therefore, we need to democratize that space. And I think that one of the things that is most important is to look at the structures, because I think there's been a tendency to, almost like a medical model, individualize things, and therefore to create a model of involvement that is kind of at the level of individuals. Whereas if we're going to kind of address some of these health inequalities, we need to deal with some of the structures in our organisations. And so with that in mind, I'm working at King's College, and we've recently set up a diversity and inclusion working group. And the focus of the working group is actually to start looking at some of the structures within the applied research collaboration that I'm in, the ARC. And so in that respect, we want to make sure that diversity and inclusion is central to everything that goes on in that research environment. And so making diversity and inclusion a standing item on all boards and committees, adding it to the terms of references, and very much exploring how we can get broader community representation and particularly making sure that local Black, Asian and minority ethnic communities are on our boards, and looking at how we can best do that. Looking at issues, at the moment we're looking at issues of Black, Asian and minority ethnic underrepresentation in our research themes, because we know that there is a problem which is national and nationwide about study participant recruitment. So there is a tendency when we're doing our research actually not to recruit from BAME communities. And so we're currently using an ethnicity data extraction form to find out what is going on with the collection of ethnicity data, both in respect to study participants, but also in respect to how research themes are involving the public as partners. And then we're also thinking about, understanding that co-production is a partnership that involves both the staff of an organisation as well as the public. We have to take on board the fact that people from certain groups are often experiencing similar issues of discrimination to members of the public. And therefore, if we're going to have a partnership, we've kind of got to look at the experiences of staff as well, because if we don't look at their experiences, then we're not going to be able to build these partnerships. So these are some videos that we've used, which are really great in exploring how BAME people can be more involved in research. And we've been using that to kind of stimulate discussions about methods that people can use. At the start of the pandemic, we held a Zoom event. We held it at really short notice because we felt that there was a bit of a build-up in the community with certain groups kind of being affected but not able to have a voice. And what we did was we timed the Zoom event with a parliamentary call for evidence of the impacts of the pandemic on groups across the protected characteristics. So this was a Zoom event in which we were specifically targeting groups with protected characteristics. And, we held it at really short notice. We had great attendance, and it really kind of challenged the notion that some of these groups don't want to be involved. I'm currently setting up a COVID research panel for the public. And this is because we've seen an explosion of research into COVID-19 and the pandemic, whilst at the same time we know that groups across the protected characteristics are probably the least likely to be involved in that COVID research. So currently looking at setting up this panel in order to give groups from across the protected characteristics a bit of a voice. So these are some of the main things that I've been doing.
You refer to the Black Lives Matter movement in a few of the questions, and also to social movement in the 80s and 90s. So I'd be interested to hear what your thoughts are on the impacts of the Black Lives Matter movement on moving towards a more equitable health system, if there is any impact at all that you've seen today.
Yeah, I think there's. I think that if you ask this question to any Black person, I really think a lot of us are going to say something similar. But actually, I also feel that the Black Lives Matter is also empowering other groups who feel disadvantaged as well. But I think one of the things that it has done is to give us permission to talk about the issues impacting on our lives, and the permission to talk about race inequalities.
So you're a Q member and an important member of the improvement community. I know you've talked about some of the challenges you face, but what role do you think improvement and improvers can play in affecting change? And what advice do you have for your fellow Q members?
So I think that some of us who have got into that field, we clearly recognise that, being able to draw upon a range of sciences, in a sense, is clearly really important if we're going to kind of drive improvement in healthcare. And so bringing together a kind of network of people who are committed to that improvement is really important. But I've really felt for a long time that that community or that network often doesn't embrace the type of thinking that I've just illustrated here about health inequalities, about discrimination, about diversity and inclusion, and really doesn't say enough about improvement located within a wider social context, rather than kind of focusing more at the kind of individual or the team level of an organisation, rather than looking at what some of the wider systemic structural issues are. So I think that there's really a need to kind of broaden the science. I think that improvement science needs to be able to allow for more critical perspectives that focus on power inequities. and discrimination, because it's really quite difficult to talk about some of those power inequities. And I do really think that they've got to sort of challenge themselves in terms of how they involve people in their own research, and how they involve people from diverse backgrounds.
And what do you think fellow Q members or others in the broader improvement community can do to enable there to be more diverse leadership and create that space for others' views to be heard?
I actually think, I do think that individual organisations and individual members have always got that responsibility to kind of look at their own practice, and to look at how they are thinking about issues of diversity and inclusion. But I actually think that bodies like the Health Foundation can play a big role as well.
Thank you. I think it's always good to challenge your own organisation. I speak as a member of the Health Foundation, and we are kind of in the earlier stages, I would say, of our diversity and inclusion journey. So I'm definitely hoping we can take on board that feedback and really build it in. You're doing such great work, Josephine. I'm so pleased to hear about the various activities, and excited to see what the outcomes are and the impacts it's going to have on improving healthcare for everyone.
I'd just like to say also that I'd like to make one recommendation that, there's a great film. I don't know if you've seen it, but I'd like to recommend that people go and see the film Harriet, because it really, it's really a great story about, how kind of one woman working with other people can take on a kind of big system of oppression. It's really inspiring, and it's something it's something that's personally inspired me in my work.
Yeah. I haven't yet watched it. It's on my to watch list, but I think it's definitely something that will keep me busy during the boring lockdown evening. So it definitely will be something to watch soon. Great. Thank you so much for the recommendation and for your time today, Josephine.
You're very welcome.